Good afternoon. Hi, I'm Teresa Caridi. We're going to be doing this session on trauma interventions, and welcome. We're going to try to keep most of the talks to 8 or 9 minutes, and then hopefully have some opportunities for show of hands, questions, things of that nature. So please hold your questions at least for in between talks. We're going to get started with Dr. Bob Morgan, and he's going to be talking to us about teamwork and how it makes dream work. Come on up, Dr. Morgan.
No, I think it's okay. Thank you, Teresa. Ladies and gentlemen, it's gives me a great pleasure to be back at the RSNA. This is the title they gave me, and I sort of thought about it for a while as to what I was going to say. So my interpretation of the title is what follows, and I hope you think that it's okay. Right. I've got no relevant disclosures. So this is what I'm going to cover. I'm going to highlight the importance of trauma teams. I'm going to review key elements of multiple society guidelines on trauma provision and provide global examples of trauma team care. Just some background: traumatic injury continues to play a role in mortality. Injury is the leading cause of death in people under 45 years worldwide. And during the last 10 years, mortality rates have continued to improve due to improved acute medical management. And factors contributing to this include better integration of multidisciplinary care, access to faster imaging and interventions, and working in trauma teams. So I thought I'd review the available society guidelines on trauma. This is the SIR recent position statement on endovascular intervention for trauma, published in 2020. And highlights from those guidelines are: there should be immediate access to an IR angio suite. There must be written protocols to postpone elective procedures if trauma patients present. And there should be written protocols for patient transfer if there is no angio suite available. The IR team must be ready to perform angiography within 60 minutes from the decision made to intervene, 60, and there should be evidence-based treatment algorithms for each trauma scenario. These are CIRSE guidelines. This is the European IR Society, and these are relatively old now. 2012 was when they were published, and highlights from these guidelines are there should be approximately 50% of trauma occurs outside normal working hours, so emergency imaging and IR should be available 24/7, and trauma care must be provided by specialist teams that must include IR. I'm from the UK, so these are the UK Royal College of Radiologists guidelines. In this document you see on the right, IR trauma teams should endeavour to begin treatment within 30 minutes of referral. I think that's a little bit steep. The 60 minutes is what the SIR recommends. And another standard: IR facilities should be co-located within the emergency department, or transfers must be rehearsed and follow defined protocols. So teamwork in trauma is a global phenomenon in intervention and diagnostic radiology, and to prove that, I asked a few colleagues around the world on how trauma care is provided in their hospital. Just chose them from many of these societies around the world. And as we're in Chicago, I thought I'd start off with Chicago. And this is Dr. Brian Funaki, who many of you will know. He works in a level 1 trauma center, where around 50% of patients have penetrating trauma, and they have a collaborative relationship between IR and trauma surgery with joint institutional and national conferences, and here's the helicopter team on the right. Colleagues from Singapore, this is Dr. Alfred Tan, and they also provide 24/7 IR coverage. They have weekly trauma MDTs, and they have 5 trauma-equipped rooms. Not far away from Singapore, this is Professor Gaojun Teng, an old friend of mine from Nanjing, China, and they also provide integrated IR care within the trauma team setting, and on the bottom is a picture of Gaojun and his team. This is an old trainee of mine from South Africa, Dr. Gareth Bidewell. They have a lot of trauma in South Africa, as you can see on these examples. The image on the right makes me feel quite uneasy whenever I look at it. He mentions that there's a current trauma epidemic in South Africa. Intentional injuries are much more common than non-intentional, gunshot wounds and the like. And this is in a population of Durban, which is around 3.3 million. He says that there are 5 specialist IRs in the private sector, but none in the public sector. So there's not very much IR involvement in trauma treatment in South Africa. They have poor equipment, and there are many challenges, as you might expect, to providing high quality IR and trauma care. There's a good trauma department, but no official trauma team. This is Korea. This is Professor Sang-Jun Park. They also have a multidisciplinary approach in diagnosis and treatment, and work closely with surgery, internal medicine and anesthesiology. They've got a robotic room as well, which they employ for some cases. And finally, my hospital. I'm from St George's Hospital in London. We have the emergency department, the CT scanner and the IR angio suite are within 50 minutes of each other, which works pretty well. We provide 24/7 IR availability, and IRs are involved in all code red trauma calls, and those are all calls that involve significant hemorrhage, and the trauma team is led by a trauma or emergency department surgeon. And so a case, we'll see many more cases in the subsequent talks. It's a patient with a traumatic splenic injury with blood in the abdomen, and here you can see in bottom right image acute hemorrhage, middle of the night. So a senior IR and resident called. This is a code red, and the patient and the anesthesiology team were transferred the 15 meters from the CT scanner to the angio suite, where we performed a splenic angiography